Ladies and gentlemen, welcome to today's NIOSH Total Worker Health webinar, Numbers to Know-How, Linking Research to Healthier Workplace Practices. Our moderator for today's webinar is Dr. Casey Chosewood, the Director of the NIOSH Office for Total Worker Health. Dr. Chosewood?
Thanks very much, Reed. Good day to all of you joining us today for our next in the series of NIOSH Total Worker Health webinars. Today we focus on numbers to know-how, linking research to healthier workplace practices. You know, data is an essential cornerstone of public health and of occupational health and safety, and in fact, high-quality, reliable data is vital to your organizational success as well. Using numbers, data sets, and surveillance, it's really critical to our informed decision-making and building a good strategy to move our work forward. So today we're going to focus on some important national data sets and take a deeper look at how your organization can benefit from these as you work to create more health opportunity and more safety and more value for the well-being of your workforce each and every day. Ladies and gentlemen, you've joined the next installment of the NIOSH Total Worker Health webinar series, and we're happy you are here. As Reed mentioned, I'm Dr. Casey Chosewood, the Director of NIOSH's Office for Total Worker Health, and on behalf of our entire program, we're delighted to have you with us today. I'm also really excited about the two presenters that we're featuring in the webinar today. First, we'll hear from Dr. Laura Linnan. Dr. Linnan is Associate Dean for Academic and Student Affairs and a professor in the Department of Health Behavior at the University of North Carolina, Chapel Hill. She's also part of the Gilling School of Global Public Health and a founding director of the Carolina Collaborative for Research on Work and Health. Dr. Linnan has more than 25 years of experience as a public health practitioner and researcher who works to eliminate chronic disease disparities with multi-level participatory interventions. She has a special focus on research that supports programming, practices, and policies to improve worker and workplace health, especially among low-wage workers and small and medium-sized workplaces. She led the development of the Workplace Health in America survey, which is a nationally represented survey of employers, which was sponsored by CDC and contracted to RTI. So we're happy to welcome Dr. Linnan with us today. Right after her, we'll hear from Commander and Dr. Sara Luckhaupt. Sara is a senior medical epidemiologist in the surveillance branch of the Division of Surveillance, Health Hazard Evaluations, and Field Studies at NIOSH. And as I mentioned, she's a commander in the United States Public Health Service Commission Corps. Her duties have included serving as a project officer for occupational health supplements to the 2010 and 2015 administrations of the National Health Interview Survey. She's also working on a project to develop a workforce musculoskeletal pain surveillance tool, a project officer during the development of the Occupational Health Safety Network, and she's coordinated a number of integrated occupational data efforts into infectious disease surveillance systems. I'd like to take a moment to set the stage for today's presentation. And to do that, I want to lead off with two questions for you. First of all, are workplace health interventions keeping pace with the changing nature of work? What new insights are we gaining about the connections between our work and our health? As the nature of work changes, and with it the demands placed on workers, the concept of work interventions for greater safety and health must evolve to meet the needs of workers facing these new challenges. At NIOSH, our research centers on optimizing our approach to this complex, ever-changing environment. What new strategies are really needed to comprehensively safeguard and promote the health of workers? The good news is that today's speakers will help us better understand these challenges in two vital ways. First, we'll hear about the current status of work health programs in the country across a number of industries and occupations and firms of all sizes. And second, we'll take a deeper, more specific look at the growing evidence base of the critical and sometimes very startling linkages between work and health, specifically between work and chronic disease. So let me ask you this. Does your job impact your health? I'll bet your paycheck it absolutely does. To better meet the changing needs of workers, a rapidly evolving economy, and a host of risks, exposures, and stressors that modern workers face, NIOSH developed the Total Worker Health Program, which works to integrate safety and health in the workplace for improved worker well-being. The program was launched in 2011 to champion this broad, holistic approach, and you can see that we really focus on policies, programs, and practices that improve the nature of work itself, maintaining a steadfast commitment to continually advancing improvement of working conditions as the boldest way to impact safety and health. Here's the breakdown. First, protecting the safety of workers is paramount. Optimizing the way work is designed and carried out is how we do this. Second, then adding in customized policy, program, and practice interventions that take into account the specific health challenges facing workers on the job and beyond, all with the goal of improving worker well-being in a comprehensive manner. You see, bad jobs, they make workers exchange health for their wages. Good jobs at least keep workers safe, but better jobs, the best jobs, keep workers safe and add to their health and their health opportunity and options. See, ideally, workers who experience the concept of total worker health on the job go home healthier every day than when they arrived. Does that sound like your workplace? We talk a lot about the 3 Ps of total worker health: policies, programs, and practices. And here's some examples of what those look like. Giving workers a voice in their work, attending to how we arrange benefits to benefit their health opportunities and health outcomes, paying attention to wages and flexibility in the day-to-day demands of the work, respect, advancement. You see, we believe that these approaches go beyond where most traditional workplace wellnesses spend their efforts. And we also see that it's impossible to overcome 8 or 12 hours of unsafe, unhealthy working conditions just by tacking on a Tai Chi class during a break or a 30-minute lunch and learn on diabetes. You see, designing work to be healthier at the outset is far more powerful and sustainable and has more reach throughout more parts of the organization. So here's my bottom line, folks. Workers come in all shapes and sizes in dozens of different industries and occupations. They're high-wage earners and low-wage earners. They're knowledge workers and manual laborers. Some folks shower before they go to work, and other people have to shower after they finish their work. But despite these differences, they all have a relatively few vital things in common. They want jobs that are safe. They want to have some level of economic security in their work. They want a job that allows for flexibility day in and day out. They want jobs that mean something to them. They want to make a difference. They want respect. Ideally, they want opportunities for growth and advancement. So despite this variety, high-quality jobs have many of those aspects in common. Before we hear from our speakers, I'll take just a moment to give you a quick overview of some of the important data sets that you're going to be hearing about today. If you're not familiar with the BRFSS, or the Behavioral Risk Factor Surveillance System, I invite you to learn more about it. First of all, it's a cross-sectional telephone survey conducted by state health departments and funded by states and CDC. It happens in all 50 states, so it's really valuable data and the possessions of the U.S. CDC compiles and compares state-level data. States, cities, counties, and tribes use the survey results to focus on interventions. Individual states' questions can vary, too. I mean, there is a core, but individual states can ask things around occupational safety and health, car safety, obesity, physical activity. So the variety of information does vary from state to state. The addition of state modules and optional elements allows us, though, to look at risk behaviors, health practices, and health outcomes by industry and occupation. This is very valuable for people planning programming in the workplace setting. I invite you to visit a NIOSH website, which is dedicated to the BRFSS here. You can also just Google NIOSH BRFSS and find that link. The next survey I'll quickly mention is the National Health Interview Survey. First of all, you're going to hear much more about this from Dr. Luckhaupt. But this is also cross-sectional. It's done annually, and it was started more than 60 years ago. It provides a variety of information in core topics, as you can see listed in the second bullet. But interestingly, it's added in a number of supplements as well, and these vary from time to time. NIOSH's Occupational Supplement in 2010 talked about work-related health conditions, work organization factors, and occupational, psychosocial, and physical and chemical exposures. So again, allowing us to cover the health status and utilization measures, disease burden, access to care, demographic trends, and disparities, really from a worker's perspective, and that really offers a tremendous amount of value for those of us designing workplace health interventions. This may be a survey you're not familiar with, but you really should be. And this is the NIOSH Quality of Work Life Survey. It's done every other year. It covers a number of important things that we know are critical to health outcomes. Work organization is heavily included, workplace stress, job satisfaction, and this more sort of firming concept of worker well-being. The 2014 survey, which is the most recent where data is available, covered important topics like depression, diabetes, arthritis, height and weight for body mass index, technology use, all in the context of those items listed under the second bullet. The 2018 survey adds additional questions around life satisfaction and well-being as well. And take a look here at the website if you want to find more about the QWL, the Quality of Work Life Survey. You may note that work stress is an important issue today. In fact, work stress is one of the most common concerns that people notify NIOSH and seek consultation. This survey not only is beneficial in organizations, but it can help you understand this work stress and related challenges that your workplace is facing. There are a few other surveys. I mentioned earlier Dr. Linnan's work with the Workplace Health in America survey. She's going to cover that extensively in her remarks. The Health and Retirement Survey, also valuable to look at aging worker issues and the transition between working longer and moving into the post-work era. The National Occupational Mortality Surveillance work is also something that Dr. Luckhaupt will mention. The NIOSH Worker Wellbeing Model, which is under development now, is another important survey that we'd like you to be aware of. And because it's not ready for prime time yet, I can guarantee you that we will focus a future webinar on this topic so that you will be able to use our new survey to help better gauge the well-being of your own workforce. I'll invite you to continue to connect with us, as many of you have already done. You can follow us regularly on Twitter, LinkedIn, and if you're not one of the 77,000 subscribers to our Total Worker Health in Action e-newsletter, we would love to welcome you to be part of our family. Heck, you can even live tweet now during the webinar, and we'd invite you to do so. Well, I've enjoyed giving you a brief introduction. Now let's shift to our first presenter. Joining us from the University of North Carolina at Chapel Hill, I give a warm welcome today to Dr. Linnan. Laura, thanks for joining.
Thank you, Casey, and thank you so much for the invitation to really have the very first discussion about the Workplace Health in America survey results, some of the preliminary results. So I'm really pleased to have the chance to talk with you. Just make sure I can advance. Great. So I want to also thank the collaborators that I've been working on to prepare for today's presentation, both at CDC and NIOSH, and our collaborators at RTI who've been part of this process all along. So a brief review of how we've approached our discussion today is to review the purpose of this survey, talk a little bit about how it was developed and our sampling and data collection procedures, and then share selected results. So I need to emphasize selected results. We have a real wealth of data, and we've tried to parse out some data that we thought would be most appropriate for this particular webinar. I'm also needing to say that want to clarify that due to journal obligations, journal article obligations, this data that I'll be presenting in the results section is actually embargoed. So please don't cite this or share it without permission. We're going to have a robust discussion today, and at the end you'll see the many different ways that we're going to be getting the data out on a timely fashion for you to make use of. But I hope people understand that journal articles, we want to make sure we get this into a good journal. So we'll have a little bit of a restraint on what we can share until that happens. So with that, I will say that we'll also have some summary and next steps to share, and we welcome your questions and the conversation that I know will happen. What was interesting from Casey's opening remarks is that several of those surveys are actually employee-level data, and what I want to make sure is really clear about this survey is this is employer data. So there's both strengths and limitations of each of those types of data. In this particular case, we'll be talking about employer-level data. Okay, so with that, we'll go ahead and move forward. The purpose of this survey was to describe the current state of U.S. workplace health promotion and protection programs in and I want to emphasize, nationally representative sample of employers, and with a focus on region size and industry types. There are many surveys out there that we reviewed in preparation for putting this together. Very few are actually representative samples. The last few that were federally funded, there was one in 85, and 92, and 99, and 2004 was the last one. So we're really excited and have been working hard to, with a bunch of great collaborators to bring these data to bear in the current data set. A second important focus was to support ongoing surveillance and monitoring. So you may know that the 2020 health objectives for the nation, for example, have work-related objectives, and so we think this data will serve as an opportunity for surveillance as well as priority setting and trends and identifying emerging issues. We also want to identify workplace health promotion and health protection issues that are research gaps and opportunities to fill those gaps. And probably most importantly, to provide free and accessible data. In all those previous surveys, that was not possible or not done. In this survey, we'll explain how we're going to go about making sure that you who are interested in this data can get access to it and make use of it for your own purposes as well. So with that, I'm going to go ahead and get started talking a little bit about the survey instrument development process. We had a national steering committee of experts from the field in health promotion and occupational safety and health who convened and got us started and helped us really shape the initial thinking about the survey. We had a data user group that was fantastic. We asked them these questions: what data do you need, and what kind of data would be helpful for us to collect? And we had a very robust discussion with them about that. And then we had a survey development team. We started by looking at the literature, of course, and 13 other national surveys that were done, including the most recent federally funded and some other surveys that have been out recently that were employer-level surveys. We created key domains and an item dictionary for those domains. We developed the initial survey. I think we went through 10 versions of the survey, got input from CDC subject matter experts all along the way, and then did some cognitive interviewing and testing of all the survey items, and then pilot tested the instrument with employers prior to it going into the field. The survey domains were really broadened from previous surveys, so we actually looked at not only characteristics of the workforce, but you can see this list here from health insurance, incentives, work-life benefits, barriers to health promotion, as well as occupational health and safety issues. We worked with a team from NIOSH to put a module together for that, as well as health screenings, health promotion programs, disease management programs, and other emerging issues. In terms of the sampling itself, the first stratifying variable was the primary strata was in the 10 CDC regions that you see here, and we started with a list from Dun & Bradstreet. We did that sampling procedure. We determined who was eligible. They had to have at least 10 employees and been in operation for at least 12 months to be eligible for inclusion. And as long as they had completed 50% of the items and had a valid response to yes or no to whether they had a health, any kind of health programming available, that incurred a completed case, and from that completed case, we also had a supplemental set of questions that we included, and those supplemental questions I'm happy to report that that sample, the 1255 you see here, also are very similar to the 2,843 completed cases that are in the larger sample. So there's only one or two places that I might mention something about the supplemental cases here, but the good news is when we looked at the characteristics, they're very similar, so we were heartened by that. Within each region, we also stratified by size, and what's noteworthy here is that in previous surveys, we only looked at 50 and above, and so we do have, in this sample, smaller size companies as well as larger size, the full gamut. And then we also have used the NIOSH industry classification by sector. So you can see that listing of industry types. So we have data by size, by sector, and by CDC region, and it is representative of the national sample. A couple other noteworthy comments that we want to mention is that we looked at worksite location rather than the entire organization, and that's important for us to be thinking about our results. Many organizations have multiple locations, but we actually got responses from the worksite location that we were speaking with. We sought respondents who were most knowledgeable or responsible for employee wellness or health and safety at this site. And we also did a telephone recruitment followed by postcard reminders. The survey was available by web, telephone, and paper modes. The overwhelming majority was done by web, and you can see the actual data collection period here. A little bit about the sample itself. The primary sample included about a little over 2,800 cases, and we did make adjustments so that we would have that representative sample by size, region, and industry types. We have, from an analysis point of view, all we're presenting today are some descriptive statistics calculated for sample and strata. We did some pairwise tests to consider significant differences that might exist between the strata, and we did a multiple logistic regression on just one issue, which I'll be presenting on, the assessing the independent predictors of having a comprehensive program, and you'll see that in just a moment. So now on to the results. The characteristics of respondents, the first thing I want to report here is that almost half reported that they were for-profit privates, and then the next largest were the nonprofits. In terms of our respondents, the biggest category was other, but that was typically managers, office administrators, general management owners or presidents, and then the second largest grouping, if you will, were health, human resources or benefits managers. In terms of the percent of work sites with any kind of health promotion program, so if you think about the definition that is the broadest definition of what health kinds of health programming might be available, about 46% of our sample said yes, they have any kind of health promotion program. And you can see that if you look at the differences by size of employer, that the larger the work site in terms of employee size, the more likely, in fact, they were to have had any kind of health programming. I want to give one example because we pursued information on many different risk factors. So things like tobacco use, physical activity programming, all different kinds of health programming. I selected out one example to share with this group that we asked about to get some detailed data from the survey on programs for musculoskeletal disorders, arthritis, or back pain. So we asked specifically, do you offer any of these types of programs for your employees? And you could see about 88% said, no, we don't offer that kind of program. But what's important, and for your future understanding of when more of this data comes out, is that we have a real wealth of information about each one of these risk factor areas. So for example, if they said, yes, we do offer, so for that 12% or so who said, yes, I do offer that kind of program in the gray, we have more information about those folks. So we wanted to try to discern, are they just doing informational programming like handing out brochures, or are they actually doing some skill building classes or groups or are they doing both of those kinds of activities? So we wanted to get away from just information only. So you could see among those, the 12% that did offer something on musculoskeletal disorders, about 8% had offered some kind of informational programming. Only less than 1% were doing skill building, and about 3.6% were doing both. We also went further and asked for each one of the risk factors that we asked about, in this case musculoskeletal disorders, arthritis, or back pain. If you did offer these programs, who typically offered these programs? And so we were trying to understand better, and from previous surveys know that health plans often are the ones that are offering these programs. In fact, here you can see for this one, about 58.7% reported that their employers were actually the ones offering these programs, or some combination of the employer and the health plan, which was the 25% that's in green. Whereas 10% were the health plan only, and the vendor was 5.7%. And then we also asked one last question, which was about what percentage of your employees actually participate in this program if it was offered. And you could see the kinds of participation data that we have available. So I'm pointing this out for musculoskeletal disorders and want to let you know that we have this for each of the risk factors that are available, and I think this is a really rich source of data for future use in all different kinds of ways. So now moving on a little bit to talk about the capacity of workplaces to offer health programming. And what we know from previous work that when you talk with employers, two areas often come out. We don't have staff and we don't have budget. So we actually tried to understand better or assess among those that have a health promotion program in the U.S., how many have any kind of budget. And you could see here that nearly 40% said, no, we don't have any kind of budget for health programming in our workplace. And what's interesting is that the next largest group was in orange is just less than 10,000 available for health programming. So that gives you a sense of budgeting. And then on the right-hand side, you see that about 72% of work sites with a health promotion program of any type reported that they had at least one person assigned responsibility for wellness at their site. And that varied by size, so the larger work sites were more likely to have staffing available. We also asked further the percent, because this is an area, especially with the ACA and new regulations, that in offering incentives has been part of the discussion that goes on in terms of health programming at many workplaces. So we asked about the kinds of incentives that employers are using. And what's interesting is about 82% said, well, overall half of the work sites said they were offering incentives. That's about 53%. And among those, we asked, well, what are you tying those to? And participation is what the incentives were tied to most often at 82%, whereas both participation and achieving a health standard were about equal in terms of that and achieving a health standard, so the other two bars here that you see. The most common types of incentives were gifts or prizes, cash rewards, and premium discounts. What was also interesting is that we also then asked a follow-up, but it's not shown here, is how effective do you perceive these incentives were based on what you did? And what was interesting is that individuals really did report that about half said that they were just somewhat effective or not at all effective. That was 55%. And about 45% said they were either effective or extremely effective. And that data is not shown here, but we found that to be pretty interesting. Okay, so now I want to just move on to an area that that is thinking about comprehensive programs. And this goes back to a definition in Healthy People 2010 that existed, and it's a way for us to monitor what changes may have occurred in comprehensive programming since our last measure in 2004. So there's 5 key elements that were identified as part of a comprehensive program. So not surprising, health education programming that we know about, having a supportive social and physical environment that would support health, integrating into the work site organizational benefits and human resources, infrastructure, environmental health, and safety initiative. So integration of programming was a third element. The fourth was links between health promotion and related programs like employee assistance programs and other programs that exist in the organization, and then screenings followed by counseling and education appropriately done on how to best use and do necessary follow-up. So we recognize that this definition does not embrace all of the many ways we now understand workplace health to be about. It is a marker. It's a way for us to understand a little bit more about what folks are doing that goes well beyond just providing information. So we actually asked our employers, which of these 5 key elements, and you could see here that in terms of on the individual elements that about 48% said that they were offering this supportive physical and social environment for health, and the second most prevalent were linkages to related programs. Fewer were doing health education programming, so that was right in the middle, and then even less were offering this integration piece or health screenings with appropriate follow-up. So when we actually then looked at the entire sample that was in this particular round of surveys, what we noticed, the overall percentage who said they offered all 5 of those key elements was at about 11.8%, you see in the blue. And you could see that for the most part, as the size of the organization got larger, so did the likelihood that they would actually be offering a more comprehensive health promotion program. Which was interesting because this next slide shows that we actually subtracted out the work sites that were, so that we could make a comparison to the last 2004 survey. So that meant that we took employers out that had less than 50 employees, and we also took out employers that were more of the public administration government category. So we had a comparable comparison. In 2004, we knew that about 7% said that they were offering comprehensive programs nationally. And you can see we more than doubled in 2017 the number of employers who are now reporting that they're offering a comprehensive program. We went a little bit further on this just to ask, what were the characteristics of organizations that were in fact more likely to be offering a comprehensive program. And very similar to the 2004 results, as a matter of fact, we found that staffing, having an annual budget, having a history of having health promotion programs, and size did matter in terms of having more likelihood of having a comprehensive program. Industry type, there was one that was less likely to have a comprehensive program, but these were independent after controlling for the other variables in the model. So, kind of interesting to see that some of those same relationships are still holding up. Now I'm going to move on and talk a little bit about the occupational safety and health module questions that we worked on with NIOSH and our national steering group and our CDC experts as well, subject matter experts. So I'm going to go through kind of quickly, but a series of questions that we asked about, and these are relatively new items to previous surveys. So we asked whether selected worker safety programs and policies, what the prevalence of those were among the employers that responded to this survey. And you could see that policies requiring and encouraging injury reporting and near misses, not surprisingly, given what we know about national guidelines and requirements and regulations. So these were endorsed fairly highly. Getting employee input on hazards and solutions was at about 88%. Having a written injury illness prevention program about 70%. We also asked about the percent of work sites with dedicated staff responsible just for safety, and this was fairly highly endorsed, a little bit higher for those in the larger number of employees, in the larger size organizations, with about 84% overall nationally reporting that, yes, in fact, they had dedicated staff responsible for safety. We know this group especially knows about total worker health, so we wanted to get at some questions that would give us some insight about that. And one of the things is, are the safety and health promotion people really working together? And so we asked about the status of their wellness committees. About 41% of our sample said we don't have any committee at all. But about 18% said that they had combined the wellness and safety folks, whereas another 21% said they had separated those two groups. And then there was individuals that had just safety, just wellness, 13 and 8% respectively. The percent of U.S. worksites where decision-making related to worker health is coordinated across departments. There was very little variation here. About 68% nationally said that decision-making was coordinated. Remember, we're talking to employers here, probably not that surprising. We had the percent of worksites that plan initiatives which jointly protect worker health, safety, and well-being. This was also endorsed, a little bit less than the last question, among the folks who responded to the supplemental survey questions. The larger sites were a little bit more likely to say that they did that joint planning. In terms of leadership committee commitment to health and safety, again, talking to employers here, so they were saying senior and middle management were highly committed, 84, 83%, but they had not really integrated, less than half had integrated that into their mission statement and in terms of health and safety, into their overall mission statement. The percent of work sites where employees and management work together on safety and health promotion, again, was endorsed fairly highly across the sample. And then just in the way of conclusions, what I want to just kind of wrap up with is that we know that the overall percentage of employers who report all 5 key elements of that comprehensive program had increased and nearly doubled between 2004 and 2017. There were significant differences by size, but fairly few. We didn't report today a lot about the region or industry groups yet, but there were fairly few differences by region or industry. That's similar to other previous surveys. We also know that there were independent predictors of having the comprehensive program, and so having a staff person just almost 10% more likely to have a comprehensive program if you had a staff person designated, and certainly having a budget, having experience of at least 5 years, and having a larger organization made it more likely to have a comprehensive program. Smaller worksites overall remain significantly less likely to offer most or all types of the programs, policies, and supports for worker health that we assess them on. Worksites were more likely to report offering occupational safety and health programs and policies than they were offering health promotion programs, generally speaking, but we know there's mandates for some. There's still some exemptions to be had there, but there are mandates on many things, so that's not too surprising. There were some differences by size and industry, fairly minimal, but there were some. And while worksites highly endorsed the idea of management employees working together and reported that there was a lot of commitment, 41% had no committee to work on this health and safety at all, and only 18% had some kind of combined health and safety committee. The overall strengths of this survey, we really had a very engaged process for developing the survey. We had input from data users and extensive pre-testing and pilot testing of the instrument. We were able to make those sample adjustments to get a representative sample by region, size, and industry. We have lots of new domains and information that we can explore with this data. I'm only giving you a brief snapshot today of that. And we have both primary and supplementary data from a supplementary sample, and there were no differences by group, so that's great. So when we can actually dig into that supplementary data and feel confident about it. There were some limitations, of course. There's no employee-level data here. The person most knowledgeable or responsible, you can't always be certain we got that person. And then in terms of this being a self-report from employers, we know there's desirability to answer that everything's great in their organization. And then we did have that issue about worksite location versus overall organizational level data. So next steps are to share these results with our steering committee and data user groups and other key stakeholder organizations, such as state health departments, trade organizations, unions, other employer groups, and vendors. We do expect to have the initial peer review manuscript on the primary results, as well as some additional papers coming out and presentations at upcoming national conferences. But really importantly, there will be a dashboard and free access to this data by size, region, and sector. If you can have a little patience with us, we're just now digging in to make that dashboard a reality, and so we welcome ideas and feedback for that. So I want to thank you very much for your attention, and I think I'm now going to be turning it over to Dr. Sara Luckhaupt.
Hello, thank you, Dr. Linnan. This is Dr. Sara Luckhaupt. Can you all hear me?
Yes, we can.
Okay. So now we're going to switch gears a little bit, and like Dr. Linnan, I would like to thank the Total Worker Health Program for the opportunity to present to you all this afternoon. I'm going to be talking about just a few examples of how my group here at NIOSH uses surveillance data to explore the link between chronic disease and work. And just a couple of transitions from the previous talk as reminders. We're going to transition now from talking about employer level data to employee level data. So talking about data collected from and on workers themselves individually. And also, rather than presenting detailed results from a single study, I'm going to just give a broad overview of a few different sources of data. And then I can answer questions if people are interested in more details about any of the data sources that I mentioned. And also I'll point you to some websites and other places to get some additional information. Now, I mentioned that this is from my group at NIOSH, which is the Surveillance Branch, SB, within the Division of Surveillance, Hazard Evaluations, and Field Studies. And I will acknowledge the rest of my team at the end. I'm a team leader, and all of my team members have been really helpful in helping me put these slides together to talk about some of the great work that they've been doing. So the objectives for this part of the talk are to summarize how worker health surveillance data can be used to explore links between chronic disease and work. And I realize that a lot of this is also about well-being in addition to specific chronic diseases, and I'll talk about that a little bit throughout. Next, to describe examples of available worker health surveillance data and results of recent studies based on these data at a very high level. And then to describe a little bit some examples of policies, programs, and practices, total worker health ways, to prevent or mitigate these workplace risks and improve worker safety, health, and well-being. So first, let me start with, what do I mean by surveillance? In my group here at NIOSH, we're used to hearing the word surveillance all the time, and we all know what it means, but some of you may not be as used to hearing about public health surveillance. So this is defined as the systematic, ongoing collection, analysis, interpretation, and dissemination of data to prevent and control adverse health outcomes. So it's really important for us to remember that it includes collection, analysis, interpretation, and dissemination. And then I always like to tell people that at least I see the NIOSH surveillance program is performing and supporting surveillance of at least two different kinds. The first is looking at cases of deaths, injuries, illnesses, and hazards that are known to be related to work, and I'll talk about that. And then the second is patterns of deaths, injuries, illnesses, and health behaviors among different groups of workers that suggest occupational risk factors just by the fact that there are these kind of patterns. So I'll start by talking about this first type of surveillance, which is a little bit more traditional occupational safety and health surveillance. And this surveillance answers the question, how many deaths, injuries, and illnesses are known to be related to work occur each year? So some of you may be familiar with data from the Bureau of Labor Statistics. And according to the Bureau of Labor Statistics, each year there are about 5,000 deaths due to fatal traumatic occupational injuries, which is 5,000 too many, and about 3 million non-fatal occupational injuries and acute illnesses that are OSHA recordable. But we know that this is only part of the iceberg on how work affects health. What do we know about work-related chronic diseases? That's what the BLS data don't really tell us. So within our group, we've been working on a study to provide new estimates of the burden of work-related chronic diseases. And this is really challenging because there is no single national surveillance system that collects data on cases of all work-related chronic diseases. And this means that we need to pull together data from various sources. There are also few diseases for which 100% of cases are definitely attributable to work, with the exception being pneumoconiosis, which are exposure-related lung diseases, really specific things such as coal workers' lung disease and silicosis. And this means that even for each disease that we look at, we need multiple pieces of information. So the study that we've been working on starts with a list of chronic diseases that are known to be related to work, at least some of the time. And based on an extensive literature review, there are about 9 cancer sites that we feel pretty confident in are related to work at least part of the time, and 8 non-cancer related diseases, including pneumoconiosis and 7 others. So we based these current burden estimates on these. Then the next thing that we looked at is what percent of cases of each of these diseases are actually related to known occupational risk factors. And so that's what these numbers in blue are. And you can see they range as high as 100% for pneumoconiosis on the right under non-cancer conditions. Yeah, the cancer condition that's highest is mesothelioma. As you probably know, that's usually related to asbestos. But for many of these diseases, we know that there are occupational risk factors, but those only account for a certain fraction of the total cases of these diseases. Such as for coronary heart disease, we estimate that work-related risk factors contribute or account for about 8 to 21% of the total cases. So based on those attributable fractions for each of those diseases that we feel pretty confident about, and the total number of cases of each of those diseases that occur each year, we estimate that there are about 450,000 to 700,000 new cases of work-related chronic disease each year, which is a pretty substantial number. But we know that there are many limitations to this kind of burden estimate too. As you saw, it was based on a limited number of conditions, 17, that have strong evidence of associations with specific occupational exposures. And you can probably all think of examples of other conditions such as diabetes or chronic kidney disease that may be related to workplace factors, but that the evidence isn't as strong to put them into this kind of burden estimate. And this kind of burden estimate requires estimates of the exposure prevalence in the population, and sometimes some of those estimates that we have can be pretty old or not that precise, and good estimates of the relative risk, meaning what is the relative risk of that disease among workers who are exposed to that specific occupational risk factor compared to people who aren't exposed. And those require complex epidemiologic studies too. It's also difficult to use these kind of data to compare estimates across different industries and occupations. So what I showed is just an estimate for all workers combined. And it's difficult to account for interactions between occupational and personal risk factors. And you'll notice even for the data that we did have that led us to those attributable fractions that we used for the estimate, the attributable fractions have kind of wide ranges because it's hard to say that certain cases are due only to those occupational exposures. So we also use another approach to studying chronic disease among workers. And that, as I mentioned earlier, is to look at patterns of deaths, injuries, illnesses, and health behaviors among different groups of workers with different characteristics and exposures. And those patterns of health outcomes can suggest occupational risk factors for further study. So one of the first examples of a system that does this is something that Dr. Chosewood mentioned in his introductory remarks, the National Occupational Mortality Surveillance System, or which we call NOMS. So the objective of this system, which has been around in the NIOSH surveillance branch for a long time, is to identify diseases that may be related to work because they cause more deaths among a certain group of workers than expected. And we do this by collecting, coding, and analyzing death certificate data that include the usual industry and occupation of the person who died and their cause of death, and looking at patterns in this. NIOSH partners with state vital statistics offices and the National Center for Health Statistics in this work, and right now we have data available from 1999, 2003 through 2004, 2007 through 2012, and we're working on processing more recent data. And state participation has varied from year to year, from 10 to 19 states per year, but we're working on improving our methods so it'll be easier for all states to participate. So where can you find these kind of data about patterns of causes of disease by industry and occupation group? Well, the NOMS query website is where we've made these data available, and I show the URL here. And over on the right is just a screenshot of what it looks like here. And you'll find access to proportionate mortality ratios, PMRs. I'll show some examples of these on the next slide. But basically, if you see a PMR greater than 100, that means that there are more deaths due to this cause than would be expected due to chance among this group of workers. And on this query website, it's kind of amazing. You can actually look at these proportionate mortality ratios for 308 different industry groups, 487 occupation groups, and 243 causes of death based on ICD-10 categories. And if you still can't find what you're looking for, then the NOMS team at NIOSH can do special analyses upon request. So here is an example of some output that you can get from the NOMS query site. What I put in here is I looked at the PMRs for deaths due to lung cancer by industry. And the circled numbers over here are PMRs that are greater than 100, indicating more deaths than would be expected due to chance among certain industry groups. So there were more deaths than expected due to lung cancer among logging workers, for example, fishing, hunting, and trapping, and different groups of miners in oil and gas extraction. And this is just a little bit of the output that you can get. There were many other industry groups that had elevated PMRs for lung cancer. Now what I'm showing on this slide is just an example of a recent study from NOMS that looked at something a little less traditional than lung cancer among different occupational groups. And this is something that one of our recent EIS officers did. And he looked at mortality from amyotrophic lateral sclerosis, ALS, or Lou Gehrig's disease, and Parkinson's disease among different occupation groups. And he found variation in mortality by occupational group, with especially high proportions of deaths due to these neurological diseases among white-collar workers, which is something that we were a little bit surprised by. And our main recommendation is for more studies to try to understand what's going on here, because it's probably not explained by the more traditionally thought of occupational risk factors for these diseases, such as chemical exposures. So that was one example of looking at mortality data. So another example of data that we look at for patterns of health outcomes among workers that Dr. Chosewood mentioned earlier is the National Health Interview Survey. And as he said, this has been conducted since 1957 by the National Center for Health Statistics, which is another group within CDC. It's an in-person household survey, and they survey about 35,000 to 40,000 households annually with a multi-stage area probability design, meaning that they consider the data representative of the U.S. population. Now, the survey each year consists of core questions and sponsored supplements. And the core questions include detailed demographic and health questions that are asked of one sample adult and one sample child from each family. And those core questions that are asked every year for the last many years have included employment status and industry and occupation of employment. So that really lets us look at the patterns of a lot of different health outcomes among workers. But then the other thing that the NHIS has had in some years are occupational health supplements sponsored by NIOSH. So NIOSH sponsored supplemental questions to get more details about worker health in 1980 and 1988, and then more recently in 2010 and 2015. And right now we're in the process of applying for funding to do another occupational health supplement in 2020. So here's an example of the type of studies that we do based on these NHIS data. And so this comes from the Morbidity and Mortality Weekly Report, their Quick Stats feature, where they just every week feature a quick statistic that looks at health. And this one is looking at the percentage of adult workers who reported being threatened, bullied, or harassed while on the job. So kind of a psychosocial occupational risk factor. And it compares the rates overall and by sex, and the dark blue bars are for 2010 data and the light blue bars are for 2015. So overall, the prevalence was about 8% of workers who said they had experienced this kind of treatment in the past year in 2010, and it went down a bit to 7% in 2015. And overall, it was higher among women than among men. And then we can use these kind of data and link it to health outcomes and look at how this may be affecting workers' health. So we've worked hard over the last year and a half to incorporate the data from the core NHIS data from many years that just looks at patterns by industry and occupation, and the data from the 2015 Occupational Health Supplement that looks at some work organization and psychosocial work factors in more detail. into this web platform that we have now called the Worker Health Charts. And this is the URL for the Worker Health Charts. And I encourage you all to explore this after the presentation if you think this might be interesting. So when you click on that URL, this is the first thing that you see is the NIOSH Worker Health Charts. It gives a little overview and explains that the purpose here is to make data exploration easier and more efficient. And it actually includes data from many different data sources, but for the purposes of this presentation, I'm mostly going to focus on the data available from the National Health Interview Survey. So this is what's at the top of the page when you click on the link. And then when you scroll down, you see these boxes, which show you the different kinds of outcomes that you can look at through this system. So exposures, health and safety behaviors, health status, illnesses and conditions, injuries, working conditions and employment benefits, U.S. workforce, that just tells you like how many workers are employed in different industries and occupations. And then the last box there is if you're not sure which outcome you're looking for, but you know which data source you're looking for, that allows you to look at the data by data source. And now all of the different topics that are in the yellow boxes here are data that come from the National Health Interview Survey. So you can see that a lot of the data come from that, but there are a lot of other data sources represented here too. And the next few slides are going to give you an example of what you can see if you click on the box for illnesses and conditions, and specifically the link for chronic conditions. Here's an example of what some of that output looked like. So you come to this page that shows you chronic conditions charts, and you can see that the data through this page are based on the National Health Interview Survey data, the core data combined from 2004 through 2013. We combined several years of data for this because that allows us to look at more detailed industry and occupation categories. And then the first thing you do is you select the chronic condition that you want to look at, and there's a drop-down list. And here I've chosen hearing difficulty as a chronic condition that I want to look at. Then you select what you want to chart, and I've chosen prevalences by industry so that I can look at the patterns among workers in different industries. And then I chose unadjusted prevalence because that gives me the best idea of the overall burden of this condition among workers in different industries. I also have the choice to choose adjusted prevalence, which adjusts for age, sex, and race, so that you can see how the different industries would compare if the people in the industries had the same age, sex, race distribution, which we know that they don't. So anyway, this is an example of the unadjusted prevalence of hearing difficulty among workers by industries. And you can see from the bars that go furthest to the right that it's especially high in agriculture, forestry, and fishing, and in mining, as you might expect. But these are pretty broad industry categories. So you also have an option here of clicking on one of these broad industry categories to get more details. So here is what happens if I click on healthcare and social assistance. It turns red. And then the next screen will break the data down into subsectors of that broad industry sector. So I've got ambulatory healthcare services, hospitals, nursing and residential care facilities, and social assistance. So just to give you an example of how you can look through the data on the worker health charts. So some future directions for the worker health charts, just to let you know, we're continuing to fine-tune the system, exploring new charting formats, and expanding the tool to include additional data sources, including the behavioral risk factor surveillance system data that Dr. Choswood talked about, and the National Occupational Mortality Surveillance System, which has the query system, but will also incorporate charts based on those data into the worker health charts. So that brings me to the third objective for my part of today's seminar, and that is to give some examples of policies, programs, and practices to prevent or mitigate these workplace risks. In other words, how can you use these types of worker health surveillance data? And my first suggestion is that you can prioritize interventions based on results of surveillance research. So another recent study based on the 2010 National Health Interview Survey Occupational Health Supplement that was recently published, we found that workers who experienced work-family imbalance, hostile work environments, or worry about becoming unemployed had a significantly increased prevalence of fair or poor health. So what are the implications and conclusions? Well, we think the following types of interventions may help mediate these negative health impacts. Organizational interventions that increase work time flexibility, organizational anti-bullying initiatives, or training programs to broaden worker skill sets or facilitate return to work from injury or illness. So we can see that those kind of programs may be needed based on the data for where the problems are. Another thing that you can do is to do a similar survey of your own workforce and compare your workforce data to national surveillance data. And you can do this using the Worker Health Charts website. But we're also working on developing some tools that allow you to do this in a little bit more interactive way even. And the one that I've been working on recently with members of my team is a musculoskeletal pain surveillance tool. And this is currently under development, but just to let you know that hopefully it'll be coming in the not too distant future. And the idea is to allow users to assess the prevalence of pain, musculoskeletal pain, meaning pain in the upper and lower extremity joints, neck, and low back among different groups of workers, and compare the results to national data, which are actually aggregate results from the National Health Interview Survey. Compare the results internally, and assess the same outcomes over time to track progress. As I said, it's still in development, but this is just a screenshot of what the tool or app, it's really an application that you can put on your laptop or other device of what it would look like. And what you'll do, you choose the data from your workforce you want to look at, choose comparison data, and customize the chart. So stay tuned for that. So in conclusion, just a reminder of what public health surveillance is: systematic ongoing collection, analysis, interpretation, and dissemination of data to prevent and control adverse health outcomes. The NIOSH surveillance program performs and supports surveillance of two types that I talked about. First, the cases of deaths, injuries, illnesses, and hazards known to be related to work. And second, the patterns of different health outcomes among groups of workers that suggest occupational risk factors. And third, you can use findings from recent studies based on worker health surveillance data or data accessible through interactive websites like the Worker Health Charts to inform interventions to improve worker health. And here's a list of all of my team members that work on some of these various data systems and help me put together these slides. My contact information if you have any questions for me. And a reminder that the findings and conclusions in this presentation have not been formally disseminated by NIOSH or CDC and should not be construed to represent any agency determination or policy. And with that, I think I'd hand the mic over to Dr. Chosewood for questions.
Thank you very much, Sarah. Excellent presentation. Also, Dr. Laura Linnan, excellent overview of the Workplace Health in America survey that really is hot off the press. So my thanks to both of you for very exceptional information today. We invite folks now to submit any questions that you may have for our speakers to answer. If you'll notice the lower right-hand corner of your screen, you have a question and answer box, and we certainly would be happy to answer some of those. And we'll pause while we wait for some questions to come into the box. I'll just mention, first of all, that I was really happy to see, Dr. Linnan, the data that shows that that more workplaces are offering what has been described as a more comprehensive workplace health program. In fact, more than doubling from the previous survey, from about 7% or so, as I recall, up to 18%. What are your thoughts on this? And also let me ask you, what other findings did you find most striking? You know, a biggest change perhaps from the first round of the survey until now?
Yeah, thanks, Casey. I think it is good news that we see that U.S. employers from this survey are indicating that, in fact, they're more likely to be offering all 5 of those key elements. And it's a little bit more than doubling what we saw in 2004. Now, 2004 is a long time ago, so it's encouraging. When the Healthy People 2010 objectives were written, the goal was to get 75% of employers. They have since abandoned that goal, I think, to some extent. So, you know, we still have a long way to go, but I do think it is encouraging that we've seen the kind of progress. And then to your second point, like any other surprising findings, I think very exciting about this survey is that it's not so much that any individual outcome would be particularly surprising. It's more that the volume of data that we have and the depth of being able to look at the kind of programming that people are doing by looking at participation data, by looking at the types of programs, we're really going to be able to discern some interesting information about the kinds of programs that people are offering. I always worry a little that we're doing a lot of information and not a lot of skill building, and it'll be interesting to see how that plays out across the risk factors that we're interested in. And then I guess one other thing that I'm particularly interested in, we have a whole series of questions on benefits and policies, more work-life benefits and policies. That's also really new information that wasn't collected before, so we don't have comparison data, but we can certainly compare it to some other national surveys that are out there. And I think having the health promotion plus these work-life policy issues together is going to be very helpful.
Great, thank you for that. You know, the other thing that struck me about the Workplace Health in America survey was this sort of perhaps a little bit of disconnect between those who had really high levels of commitment for combining some of their safety programs with broader health programs, but not necessarily a committee. You know, the commitment was there, but the committee wasn't.
Yeah.
And I know that certainly I see that as a real area of opportunity. How about you?
Yeah, definitely. I think there is a little social desirability going on when everyone's saying top managers and middle managers are all very highly committed. We hope that's true. We really do hope that's true. But when you then see that less than half were actually had any committee at all that had employees engaged in the process, you just have to believe that they could go further. I mean, it's room for improvement. That's what I think we want to encourage employers who are looking at this data to say, you know, where can we grow? Where can we do more? And can we get more employees involved in really creating a healthier work environment? And it will take a look at those work conditions and see what, in fact, we can work on together to improve the health of our workers and our workplace.
Yeah, absolutely. Many of our folks online who follow Total Worker Health know that, you know, this is a key tenet, this sort of combining at the operational level of safety committee and workplace health committees and sort of combining efforts and using that potential synergy is part of the fundamentals of Total Worker Health. And for those of you who want to know more about that, certainly visiting our website and looking at the fundamentals of Total Worker Health in the Let's Get Started page. Sara, I have a broad question for you, and then I see some coming in from the audience that get down into some details. But let me just start by asking your thoughts about cardiovascular disease. And you mentioned the attributable risk or the attributable fraction for work relationship between cardiovascular disease outcomes, about 8 to 20%. So this is substantial, especially when you really keep in mind that most Americans will die of cardiovascular disease, and it's certainly the most common cause of death for folks in the working age population. So this really represents a tremendous burden if there is perhaps up to 1 in 5 cases of cardiovascular disease, something we know that's causing a lot of deaths, that's caused by work. What are your thoughts on that, and what are the opportunities to change working conditions to address that?
Yeah, well, thank you. That's a very good question. And first I'll start with just a little bit of clarification that attributable fraction of 8 to 20% is for deaths due to cardiovascular disease among quote-unquote working-aged adults, so ages 20 to 69. So as we know, a lot of deaths from cardiovascular disease happen later on after you're not working, or even in people who are working that are older than 69. But anyway, so this is just focusing on that age group of 20 to 69. And the other thing is that this estimate, the overall estimate of 8 to 20% being attributable to work, is just based on 4 occupational risk factors that we have pretty good data on for the risk ratios. And those are environmental tobacco smoke, noise at work, shift work, and work stress. And I say we have pretty good data, but actually we definitely need better data on all of those. And we also know that there may be other factors in the workplace that may contribute to heart disease that aren't even being captured by this this estimate. So this just emphasizes the need to look at the prevalence of other factors associated with cardiovascular disease and early markers of cardiovascular health, such as hypertension and high cholesterol among different groups of workers, to try to understand this even better.
Great. Thank you for that insight. Catherine has asked Dr. Luckhaupt, can you again go over the difference between adjusted and non-adjusted data on the worker health charts?
Yeah, I can talk a little bit about that, and I'm sorry I went through that kind of quickly, which is it's actually something fairly complicated. But when you look at the worker health charts, you can look at the data, the prevalence data by age, education level, ethnicity, gender, or race, and that's fairly straightforward. But then when you look at the prevalences by industry, that's when you have a choice about whether you want to look at unadjusted prevalence or adjusted prevalence. And we offer both options because we weren't quite sure which people would be more interested in, and it kind of depends on what you want to look for. So if you want to just look at what % of workers in a certain industry have that health outcome, then you should look at unadjusted prevalence, and it will tell you that X % of workers in agriculture, forestry, and fishing have hearing difficulty, for instance. But if you think to yourself, well, what if workers in agriculture, forestry, and fishing are older than workers in, say, services? You know, is that why they maybe have a higher prevalence of hearing difficulty? Is it because of their age? That's when you might want to look at adjusted prevalence, because the adjusted prevalence takes age, sex, and race of the workers within those different industry groups into account and shows you what the differences would be between the industry groups if they all had the same age, race, and sex distribution. Hopefully that helps.
Yeah, absolutely. Very, very helpful. Thank you for that. We have a question that I want to really pose to both of you because each of you touched on it in different ways, and it really has to do with looking at behavioral health issues. And I know, Laura, that there are components of the Workplace Health in America survey that look at some of these areas, especially around work and life integration and work-life benefits data. And one of our attendees today asked, how can I find out more about that? And then I'll ask Sara to chime in to talking about what we can learn from like the National Health Interview Survey and behavioral health as it relates to work. But Laura, we'll start with you.
Okay, we didn't really report a lot on that, but I was kind of kicking myself when I mentioned it because I realized that would have been a good one for this particular group especially. And we did a quick lookup. For example, just how many work sites are offering employee assistance programs. 55% of the overall sample didn't offer any employee assistance programs, whereas about 13% offered them for employees only, and 32% offered them for employees and their families. That's in the overall sample, and we haven't looked at anything on size or region or industry sector on that. But then we had these series of questions, and we worked with, there's actually been national surveys of work-life policies. I can probably follow up with you to get the actual site for that. That was in one of the 13 surveys that we reviewed. And we had one of our collaborators on our survey development team that actually worked on that survey for the organization sponsoring it. So they had just a phenomenal survey. We took a subset of their questions. So we asked things on whether the employer allowed unpaid parental leave. About 77% of our workplaces actually said they did, offered disability leave, offered flexible work schedules, and that's one that we know is so important for, all workers. And about 55% of the work sites in our sample said that they in fact had offered flexible work schedules. Offered paid family leave, about 43%, allowed employees to work from home, about 36%, and helped cover child care costs, 27%. So that's just a snapshot of a couple of the items that were in that module. The whole survey is modularized. So the work life, there's a few other questions on there, and I think there might be a couple additional in the supplemental questions. But that gives you a little bit of an idea of the kinds of information we have available. I hope that helps.
Yeah, absolutely does. Sara, your thoughts on some of the behavioral health outcomes and the surveys you mentioned? Sara, could you possibly be on mute?
Oh, I'm sorry. I think I was. Yeah, I was just trying to think of what all counts as behavioral health outcomes here. But just building a little bit on what Dr. Linnan talked about, the different things that we learned about the availability of policies from the employer perspective, is that one thing we were able to get from the National Health Interview Survey in 2015, which I think sort of complements that data, are the employees' perspectives. And some of the things that we called psychosocial work factors might be relevant here. And if you look on the worker health charts under psychosocial occupational exposures, you'll find things like 25% of workers reported work-life interference, and 11% were worried about losing their job. 13.7% had low job control, and I already talked a little bit about hostile work environment. So these are the kind of data that are available through the National Health Interview Survey. And just looking at the worker health charts, you can just see how common these different exposures are. But then we've done some studies to look at how the associations are actually related to different health outcomes. And also, I might mention that the data from the National Health Interview Survey are publicly available for others to do studies too, because there are just so many different ways that we could study it that there's no way that we can do it all ourselves within NIOSH.
Great. Thank you for that, Sara. I'll take a break just from the questions for one moment. We do have a few more that we would love to get to, but just a break for a second to alert folks who may not be aware that if you're interested in the topic of total worker health, your timing is perfect, because if we've whetted your appetite today and more information about this area of research and practice is desirable, we invite you to join us at the Second International Symposium to Advance Total Worker Health. Going to be on the campus of the historic National Institutes of Health, just minutes from downtown Washington, D.C. And it's on May 8th to the 11th. Early registration deadline is closing soon for those who want a less expensive registration. And we do have a limit to the number of people who can attend, so we invite you to take a look at this symposium website and register. We'd love to get to see you in person. I'm happy to report that Dr. Linnan and Dr. Luckhaupt both will be speaking at the symposium on related topics to their presentations today. Let's get back to a question. Here's a specific one for you, Sara, on NOMS. And it specifically asked about output from the NOMS query site, PMRs for deaths due to lung cancer. And the question is, does this data extract the adverse lifestyle factors of these particular occupational groups, or is it really rather highlighting where some of these risk factors may be?
Yeah, that's another good question and another good point of clarification. I assume that what the person is thinking about is things like, when you look at lung cancer, does it take into account smoking? And the quick, easy answer is no, it doesn't. So that is true that there are definitely the chance that personal risk factors could be accounting for, in part, some of these differences that we see among different industry groups. And that's one of the limitations of the NOMS, is that we don't have a lot of data on other risk factors. But one thing that you can do, if you're curious as to how it might be affecting the results, is to look at other sources of data to see what's the prevalence of other risk factors among different groups of workers. So another type of data available from the National Health Interview Survey that's incorporated into the worker health charts that relates to the previous question too, I think, is the data related to health behaviors that are there. And if you look at the worker health charts data under the topic of health behaviors, then you can look at the prevalence of things like current smoking or any alcohol use or obesity among different groups of workers in different industries. And you can compare that to some of the findings for causes of death you're seeing on NOMS. And although they're not coming from the same data source, it's not the same as doing an in-depth study. You can get some ideas of some hypotheses about what might be going on.
Exceptional answer. And to me it argues for this comprehensive approach to worker health. Those challenges that are facing workers due to the nature and the design of the work, as well as some of the personal health choices, behaviors, decision making, and how these interact, and really, with complex issues like tobacco, for instance, how the workplace and changing the nature and demands of work can potentially be an opportunity to intervene for some of these real challenging health conditions. Dr. Linnan, do you see any straightforward way to move those companies that don't have any budget at all for moving their workplace health program forward and maybe no identified health and wellness leader? Any strategies that come to mind for helping them make that a priority? I mean, certainly seeing the success of other companies that do have dedicated staff might be a start.
Casey, I think you're absolutely right. I think getting stories out there of companies that have been successful and what the impact has been when they've gone down this path to trying to create a healthier workplace and conditions for their employees, and the fact that they can potentially retain and recruit employees at a better rate, perhaps. There's a number of different outcomes. But I think hearing from examples of success, the fact that there's no budget, I've actually personally, when I was still doing practice-based work and not in the academic world so much, I worked with employers to help them get started from nothing, some really small companies as well as some larger companies. And so it's very possible for it to happen. There's got to be some level of commitment at the top. Sometimes the commitment can come from the grassroots, from employees who are interested. But I think in the absence of having some kind of employee engagement in the process, we really don't ever fulfill the idea of having a really engaged workplace where health and safety are priority issues. So you need that commitment at the top. That usually what will follow are some resources, so then budget will come along. But there's things you can get started on. You can take a look at the policies and the work conditions and say, okay, we have policies that are not supporting health in this work organization. Sometimes some of the policy changes don't come with a huge price tag or any price tag. So starting small, building on that, seeing the success, and then as you do that, if the commitment is there from the top of the organization and or from the employees, they'll get resources to come to bear over time. But I think you start small and have some early success and build on it.
Great. Thank you for that. We've got an interesting question that is what I might consider a legal question, and I'll just read it and then give you my response as someone who's been a practitioner in this field, and I can speak from just my own anecdotal experience here. And the question really involves workers' compensation and injury after participation in a wellness program. So I'll just read the question outright. It says, I recently listened to a workers' comp attorney speak on how some injuries can be compensable when employees are injured while participating in a wellness program under certain circumstances and incentives. Can you comment on this? First, I'll just lead off by saying that workers' comp laws vary from state to state. In fact, there is no federal workers' compensation system in this country except for federal employees. So for those who are in the private sector or in state and local government, workers' compensation decisions are made on a state-by-state basis. So we really have 50 or more different approaches to the way workers' compensation decisions are made in the country. It's been my experience, though, having led both in the private and the public sector a number of these intervention programs, that the benefits of these programs far outweigh the risks for liability related to injury while participation. In our own program for our own NIOSH workers, we've had a tremendous success by putting in place a walking workstation program where people can be productive at work while walking at a controlled 2 miles per hour. And certainly some of the early critics says, oh my goodness, you're going to have people falling all the time. Well, we put a number of protections in place to avoid that, and we've been very, very successful in carrying out a very highly popular, health-positive, forward-looking walking workstation program with really no major downside or injury or illness related to that. Of course, we train people how to use it. The walking workstations are governed at 2 miles per hour. We make sure people are cleared to be physically active before they begin any kind of health program and through our fitness facilities. So we have a number of protections in place to help people make good decisions and choices before engaging in any of the health activities. But it's the consensus from our own experience and the literature that the benefits of these programs far outweigh any liabilities that might arise from them. Here's another question, and we are wrapping up. This may be our last question, and I will ask both folks to weigh in with a response. And that really is, I think, a general question about the benefits, if you will, of integrating safety and health efforts. And whether you use data from your own research or just your thoughts in general, I would welcome each of you to talk about what you see are really the synergies that can come from trying to combine safety programs with broader health interventions. And Laura, we'll start with you.
Yeah, thanks, Casey. I think I can't really think of doing the work that I do without an integrated approach any longer. I think, for years, there's been these siloed approaches to health promotion and safety, and I think if you're thinking about organizations who are really moving forward and have that commitment to healthy workers and healthy work organizations, it's part and parcel of having that commitment that will extend to thinking about the work conditions and the kind of work that people are doing every day when they come to work. And if the work conditions are in good shape and people are feeling supported and are supported, and if there's hazard-free conditions, people are going to be able to pay more attention perhaps to their own health and feel valued at work and feel the commitment that exists at work and be in the human capital part of work will work both for the organization and for the individual. So I think the integration piece is essential. Getting employees involved is essential from my own experience, and I'm looking to really make use of the data that we have. I've learned some new data sources today thanks to Sara's presentation, and I think the Workplace Health in America survey can contribute to that ongoing dialogue about what are the strategies that work best and how we can get there together.
Great. Thanks so much, Laura. Sara, we have about a minute left.
Yeah, I guess the only thing that I would add to that is just how interested I've been to see from some of the work that I've done, like the study that I talked about where we looked at job characteristics associated with self-rated fair or poor health. How interesting it is that the characteristics that you see the high associations with, like work-family imbalance, hostile work environments, and worry about becoming unemployed, those are really work characteristics that I think can only be addressed through an integrated approach. And that we found that, at least in some cases in many workplaces, these are more highly associated with workers' health than what you think of as some of the more traditional occupational risk factors and exposures, and how important integrated approaches would be to addressing these.
Thank you both for that wonderful insight this afternoon and for the great content in your presentations. Ladies and gentlemen, we've enjoyed spending part of your day with you today. If there's any way the Total Worker Health Program can help you advance the health, safety, and well-being of your workers, we'd love to hear from you. You can always reach us at twh@cdc.gov. Thanks for joining. Have a great day.